Hi, I'm Pieter van Eijsden. I'm a neurosurgeon at the UMC Utrecht, and I mainly specialize in oncological neurosurgery and epilepsy surgery.
So, when you have a patient and he or she is diagnosed, what are the steps that he goes through in his patient journey, in his treatment process?
So if we start at the beginning, of course, a patient first needs to have complaints. And generally speaking, a person will suffer from epileptic seizures or have some sort of neurological deficit, and then will either go to a general practitioner or to an ER, and then usually they are referred to a neurologist, and in this stage usually some form of imaging is done, like a CT scan or an MRI scan. And that's usually when the neurosurgeon gets involved. So at least one and usually two other doctors have already seen this patient. That's why we are called a tertiary specialism. And by the time we get involved, we already know a lot. And for instance, we already know the diagnosis, which is completely different from a GP who almost never knows a diagnosis when a patient comes in. So let me then begin with the point at the point that the patient comes to me. At this point, the patient also usually knows his diagnosis. And they know that they are referred to a neurosurgeon because this is possibly something that can be treated by surgery. We moeten denk ik even een break maken. Ik zit me nu een beetje af te vragen of we dit vanuit het perspectief van de patiënt moeten bekijken of vanuit... Want het is een beetje lastig omdat die mensen natuurlijk een heel traject hebben doorlopen voordat ze bij mij komen. En ik kan wel iets vertellen over, maar daar ben ik dan niet bij betrokken. Hè?
Dat is goed. Gewoon nu eigenlijk liever gewoon wat jij nu zit. Van, het gaat ook, het hoeft niet het volledig te zijn. Het gaat even om een soort van inzicht te geven. Wat je nu verteld hebt tot het punt dat jij kwam, meer dan diepgaand genoeg.
Okay. So then a patient is referred to me and I then usually have, for instance, a lot of scans. Many times we have already discussed this patient in a multidisciplinary meeting where the neurologist or the clinical neurophysiologist or the oncologist has presented this patient as a possible candidate for surgery, and in this meeting we have said, well, this seems like a good option, and then refer the patient to me and then we'll discuss this with the patient. And what's important to stress is that in some cases I go into this conversation with the patient with almost 100% certainty that this patient is going to be operated by me. But at other times I'm really not sure where we are going to end up. I may have a preference, but the preference of the patient is also very important. So when the patient and I see each other for the first time, I try to explain this to the patient, that we are trying to find common ground. So that's why I usually ask the patient to tell his story again. It's usually the third time or 10th time that he's going to tell his story, but I don't always say, I know this is very frustrating and I have everything in the file, but I want to hear it from you in your words, because it makes it a little bit easier for me to understand what sort of person you are. And if I don't have a lot of time, I sometimes do it the other way around, and then I tell the patient, this is what I know about you, and if I get things wrong or if you want to emphasize things, please cut in. So then we have the whole story, and then I usually move on to the scans. So this is what we see on the scan, etc., etc. That means this and that. it is, for instance, a tumor that is very near the area important for movement of the hand, and so that they understand a little bit about the organization of the brain. Then I move on to the way we do the operation. Just we start by cutting the skin and just the whole process of the operation. And then I tell them something about what they have to gain and what they can lose. And I always do this. Because this is the most important thing there is, right? It's like the balance of good versus bad. And sometimes it's very obviously this, and sometimes very obviously this, but many discussions are like around that 50-50 margin. And then I ask patients to reflect on that, like what are you thinking, what do you think about this? And then sometimes people have a very clear idea of what they want. Usually they will say, well, I knew I was going to a neurosurgeon, so I knew that surgery was going to be an option, and this sounds like a good plan. But the more experienced I get, the more often I tell patients, well, think about it for a week and we'll see each other again next week. So you can have some time to think about this with your family and with your friends. And just take some time to come to a good decision. And maybe you have additional questions and we talk about it again next week. And I'm pretty happy with that way of doing things, because I think that people need some time to really grasp what I have told them, and also to really understand what their priorities are in life, especially if we talk about oncology. Almost all these patients have a limited lifespan, so we know that they are going to die of that tumor, and they will have to think about what they want to do at that time, and whether they want to make the sacrifice of going through surgery to have a little bit more time, or whether they don't want that, and how to assess the risks that are involved. And if they have to make a decision on the spot, they will almost always say, yes, I want this. But if they think about it for a little bit, they more often say, well, I've had a good life and I really don't see any value in going through surgery and all kinds of other things and then maybe live a couple of months more. This is really not what I want. But anyway, once we get to the decision to go for surgery, then I always have to type a lot of things into the electronic patient file, and then patients are referred to the anesthesiologist, because the anesthesiologist wants to know whether they have had operations before and whether they have had problems during those operations and a lot of other things. And I give them some information of our oncological nurse, who is available 6 days a week for phone consultations and as an intermediary between the patient and doctors in the hospital. Then the patient is on the waiting list, and then behind the scenes I have to negotiate with the planners and with my colleagues when well, this is really how it goes, right? When I can operate this patient. Then our planner makes a week plan, and she calls all the patients for that week on a Wednesday or a Thursday. So that's when the patients hear that their operation date. They come in almost invariably the day before surgery. They have another MRI scan, which is